No. Osteoporosis is reduction of bone strength. Why is it so important? Because about 10 million people in the United States of America suffer from osteoporosis, and 48 million people suffer from osteopenia. That means weakness of the bone. That's a sum of 58 million people. This slide demonstrates the change that aging and medication makes the bone fragile and porous. Osteoporotic fractures occur in 1 to 3 women throughout their life, and 1 in 5 men. And it occurs about every 3 seconds worldwide, and 2 million per year in the United States. It's a very, very big sum of the patients, and a lot of suffering is done. This is another picture showing what happens to the bone by aging. It's a silent disease. The problem is that no symptom until there's a fracture. People can suffer from kyphosis and loss of height by the aging, and this slide demonstrates what's happened to the spine. Microfractures occur in the vertebral spine because of osteoporosis. This X-ray demonstrates the wedge fracture and loss of height in the vertebral spine. Some are asymptomatic. You must take an X-ray. You can find it in normally walking and working people. WHO considers it the second global healthcare problem, and I'm sorry. This came out. The chance of dying from cancer, breast cancer, is equal to osteoporosis for a woman over 50 years of age. That's interesting. Nobody cares about osteoporosis, but women care a lot about breast cancer because they can feel the suffering. Why is it so important? Hip fracture leads to deep vein thrombosis and pulmonary emboli in up to 50% of the cases. 20 to 40% of hip fractures don't come back to their normal life, and they need long-term care. That means it's a very, very devastating and serious problem to have a hip fracture. This is a normal curve of bone. It starts at birth. We have a rise in bone density and bone mass until about 40 years of age. And regardless of the condition, after 40 years of age, decline starts. Any insult on this curve will lead to a lower bone density, like oophorectomy, the blue line, or people who have hypothalamic or nutritional problem don't have the peak bone mass, and when the peak bone mass declines, the fracture occurs earlier. Osteoporosis, drug-induced osteoporosis, the most common drug is steroid. Cyclosporine, in the field of rheumatology, actually 2 drugs are the most used and problematic drugs are cyclosporine and steroids. Cyclosporine usually is prescribed with steroids. There's no good study to evaluate the function of cyclosporine individually as an agent that induced osteoporosis. But we must be careful when we prescribe cyclosporine. Glucocorticoids inhibit osteoblasts, stimulates bone resorption, impaired calcium absorption, increased calcium loss, urinary calcium loss, and suppresses adrenal and testicles and ovaries. And at foremost, myopathy increases the chance of falling down and the chance of fracture. There's a rapid decline of bone density in the first 3 months. The first 3 months is a very critical time for treating patients. And it's followed by a steady state of bone loss with continued use. We can have increased risk of fracture with even 2.5 milligrams of prednisolone for 3 months. And the population that already has a risk of fracture, a small insult in the bone mass will result in an earlier fracture and death. The association of risk fracture and use is a cumulative dose. The cumulative dose correlates with the risk of fracture. New fractures occur up to 70% after 1 year of steroid therapy. 30 to 50% of people on chronic steroid have asymptomatic fractures. Although it's a very important health issue, management remains suboptimal to multiple studies, and patients are undertreated. Timing is the most important issue in treating these patients. Steroids may help bones in some way. Pro-inflammatory responses can be blocked with steroids. These pro-inflammatory responses induce osteoporosis. But the balance of steroid use in rheumatic patients leads to osteoporosis. The help is much lesser than the harm. The mechanism of why osteoporosis is induced is incompletely understood. What should we do? We should work on prevention. Patients with high risk of fracture needs treatment, and patients who will be high risk during the course of treatment should be treated. The gold standard is to take a dual energy X-ray absorptiometry or DEXA scanning from the patient to evaluate the bone mass. WHO has developed a method of measuring bone density. It is comparison of the age of 30, that means peak bone mass, with the current condition. It is defined as with how many standard deviations there's a difference. If we have a 1 standard deviation difference, it's not a matter, it's considered to be normal. If we have more than 1 and less than 2.5 standard deviations, it's considered osteopenia, that means weak bone. And more than 2.5 standard deviations, lesser than peak bone mass, is considered osteoporotic. Measuring the bone mass is not 100% correlated with the fracture. WHO developed a method of fracture risk estimation. It's a software that's available on the internet. It's called FRAX. It gives the 10-year probability of hip fracture or a major osteoporotic fracture. The people may have high risk of fracture and have a good bone density. It's better to focus the treatment on the risk, not on the exact data extracted from the machine. To treat bisphosphonates are the choice to start. They're more widely used. Their efficacy is being approved, and FDA has approved alendronate, risodronate, etidronate, and zalendronate for the individuals who take glucocorticoids. Zalendronate or zalendronic acid is the intravenous form that's helpful in treating patients. We can use parathyroid hormone. Injection of parathyroid hormone helps stimulating the bones formation, and it's actually the only medication that has a positive effect on bone density. The previous medications the other medications in this field have decreased bone turnover. They decrease osteoclast activity and osteoblast activity. That means the balance of osteoclast activity and osteoblast activity is in favor of increasing bone density with decreasing the turnover of the bone. When you have decrease in the turnover of the bone, the quality of the bone declines. But PTH doesn't have this issue, and the quality of the bone produced by PTH is a very good quality. Vitamin D deficiency is increased because of increased prescription of sunscreen by dermatologists and decreased sun exposure. Beneficial of adding vitamin D and calcium in treatment of osteoporosis have been shown in few studies, but there's not a universal agreement about it. Not all of the studies have shown this benefit, but people should use the vitamin D and calcium Who should be treated? It's a difficult issue. American College of Rheumatology suggests -1 Z-score. Z-score means the T-score. T-score means the comparison of the 30-year-old with the patient. United Kingdom guidelines suggest -1.5 T-score, and Dutch guidelines suggest -2.5 guidelines. That means this difference reflects the difference of resources of the medical and financial status of the country, weakness of current evidence, and weakness of the studies, and it's overall it's recommended not to treat a patient according only to the T-score, the number that comes out of the machine. We must consider all of patients' clinical condition. FRAX has a consideration of steroids, but the FRAX uses low-dose steroids for evaluating. Only one box you can click. If patient takes more than 1 milligram prednisolone per day, FRAX is not good. FRAX is good for low-dose steroid, but you should consider that if you're using high-dose steroid, FRAX underestimates the risk. What is recommended? It depends on the patient. American College of Rheumatology wanted to revise the criteria of treating osteoporotic patients, but it didn't come out. I even checked it 2 days ago. It will come out, I think, at most 1 or 2 months later. But for now on, till present time, if patient has no fragility risk of fracture, a healthy young athlete, no treatment is necessary. If patient has childbearing potential and wants to have a baby, wants to become pregnant in the case of the woman, and uses 1 to 3 months of corticosteroids, no treatment, no consensus, no treatment proved studies present, and we can wait. Women and men over 50, women not wanting a child or non-childbearing age, and men over 50 with glucocorticoids for more than 1 to 3 months. If prednisolone more than 5 milligrams per day, alendronate or risodronate is suggested, and if prednisolone more than 7.5 milligrams per day, zoledronic acid is recommended. The problem is that this is the patient that goes to his rheumatologist or endocrinologist or primary care physician, has a bone densitometry, and they tell him everything is okay, but comes to you for pemphigus and needs a steroid. Prescribing prednisolone needs reassessment of previous plan. And if a patient is less than 50 months, 50 years, men, and non-childbearing women, glucocorticoid more than 3 months, tetrapride or PTH should be considered in addition to the other previous medications. Thank you for your attention. Any questions?